On from a very interesting topic to just the basics, how to quantify, and an advisory for the students. I'm going to be asking you questions. So, like always, so please look up from your phones. Time for questions. So the first question is, we all know hepatic steatosis measurement is important, and sir has already elaborated on it. I'm not going to go ahead with it. The only thing I want to point out here is that all these etiologies that we know of, HCV, alcoholic liver disease, apart from other CLD etiologies, can themselves be steatogenic. So it's not necessary that we have to have fat beforehand. If a patient develops hepatitis C, we have to screen him for fat as well, and then metabolic syndrome, everything has been spoken of. We know there is a large prevalence of fat even in Eastern societies, and what we want to look at today is fat estimation. So what are the existing methods of fat estimation? Anyone? Orange. What are the existing methods you're using here in the OPD every day? Sorry? Louder. No, BCG, okay. What else do you send for patient every day? Sorry? Use a mic. You all have mics on your chairs. Which is the commonest investigation you all are sending for? You all have mics by your chairs. Use them today. Which is the commonest one you're using?
I'm PhD student, not a...
You're a PhD, okay. Whatever, you still know, you get relatives here for checkups.
I'm for lipid profile. And
okay, we're talking about imaging.
Fibroscan.
Fibroscan. So the commonest one we're using here is a point of care fibroscan. I'm going to talk to you about that as well, but let's start with other ones, and then I'll move on to ultrasound, which is the main topic. How are we assessing fat on ultrasound modalities? So a very favorite modality for me as well as for the surgeons is the fat estimation on CT. You, second row, second one. Is this a plain CT or this is a contrast CT? Very good. But why do the vessels look bright? Yeah, you need to use the mics. So the liver is dark here, very good. So what he's saying is true. When you have fatty liver, that's what happens. The attenuation of the liver tissue reduces because of the increased adipocytes within the hepatocytes. And that's when the unopacified vessels start looking bright. What is the commonest differential for a liver which looks dark on CT and is a plain scan and is enlarged as well? For example, this liver is enlarged. We know the left lobe and the caudate are enlarged. The margins appear smooth, but it's still dark. Somebody else. You take it? What is the commonest differential? Which is why I need the history all the time and I keep calling up to ask, is the patient oriented or not oriented? Is the patient having raised markers? So what is the commonest differential I would have? I'll give you a choice, okay? ALF, CALF, fatty liver, or a deposition disorder. Wilson's.
Deposition disorder?
No. So deposition disorder is going to cause an increase in the density of the liver, but your ALF patient, which has a lot of parenchymal edema, is the one that is my biggest differential for a steatotic liver. So I usually will not report it as steatotic attenuation. I will report it as reduced attenuation. So both the things cause reduced attenuation, which means edema as well as fat, both cause a reduction in the attenuation, and the clinical picture of the patient is as important as the estimation of HU. So nothing is, it's objective, it's just subjective, but has to be correlated with the clinical history. So unenhanced CT is one of the best CT methods for liver fat. We have a whole gamut of CTs now. We have a dual energy CT, we have quantitation on dual energy CT. There are equations and formulas which we can use to actually calculate a percentage, which the MRPDFF gives us. So we have a dual energy CT application, and now we're getting photon counting CTs, which are further better class of CTs. So CT is a great modality. We are using this for our transplant program for years, and I think it's worked out pretty well. So what do you do here? You take a lot of values. These are the region of interest. These are the ROIs, and we calculate the liver minus spleen index, which means the hepatic attenuation. We usually take 5 sections. We take 5 values on both sides. So we get 25 values each, and you subtract the 2 and you see which one is usually bigger than the other. Last row. Orange, yellow shirt. You, yeah, next to the purple one. Which one is higher, liver or spleen, usually? Are you a PhD student too? Do you think, so you would know something about labs. So, okay, let me rephrase the question. So what tissue, whether liver or spleen, should be denser? You can take help from pathology.
Liver.
Which one will be denser?
Liver.
Sorry? Which is a denser tissue? More dense.
Physical.
No, Sanal, faculty is not allowed to answer because you are faculty.
Ma'am, liver.
When they can't, we'll pass the question to you.
Ma'am,
They can, they're all very bright. Yeah. Which one is a denser tissue?
liver.
Liver.
Yes,
So
ma'am.
speak up. Why is liver brighter? Why is liver denser? Behind you. Yeah, you tell me, Kavita. Why is the liver denser? What is the composition? What component of the liver makes it denser? You can pass on to the next one if you can't answer. Or take help from your friends. What does it contain? What is it in the liver tissue that makes it darker or brighter or let's say more denser than spleen, which is why we always look at the spleen and liver? The glycogen. So the glycogen in the liver makes it, denser, and it's always brighter on CT and on ultrasound. Also, you'll see what happens there. So the glycogen in the liver on CT gives it a higher attenuation. So we always subtract liver from and spleen attenuation. It should always be higher. So the liver should always be higher than the spleen, and spleen is the best tissue. Which is the other tissue we can take for calculating CT values? Which other tissue has no inherent adipocyte in it? Which means if you put on fat, which Sir just explained to you, which tissue will not take on fat? Apart from liver, liver of course, but spleen. Spleen will not take up lipocytes, right? Which other tissue doesn't have lipocytes of its own? There are 2 more. 3 more actually. Anyone? Next row? 1, 2, 3rd. 4th row. You were all sleeping. White t-shirt. No? Okay, next one. You can't say no. I'm not going to let it pass beyond this, 4 of you. Help each other. Which tissue has no fat? If you put on fat, that's not going to put on fat. Why do people go to the gym? Because they want to increase the muscle mass. So if you want to compare your liver and spleen and other tissues, muscle. So a lot of studies going on in ILBS with paraspinal muscles and muscle. We are seeing the intensity on CT especially, and we have a lot of software. So muscle is another tissue which you can compare your attenuation index with. So liver and spleen is usually used. Muscle is being used now more frequently, where we are assessing visceral fat vis-a-vis non-visceral fat, where muscle is the gold standard for reference. So for donor selection at ILBS, in the initial years we used to use this, and now also we are using the CT values, and it's worked out pretty well, except for a few exceptions which are bound to happen with anything. So we do a donor selection, we take a liver minus spleen. If it's more than 10, patient is fit to go. If it's between 5 and 10 HU, the difference, then you do a biopsy or an assessment, or you ask the patient to lose weight and come back and you reassess the patient, or you use another modality. And if it is between 0 and 5, it is not considered fit for transplant. So new softwares today can automatically at the click of a button give you an attenuation of the entire liver and spleen and calculate the values and give them to you. And their studies now quote that they're almost 99% specific. So CT is a great modality, but what is the biggest limitation? Why are we not using CT then if it's so good? The sensitivity for less fat or mild steatosis is very low. It's 57% only. You have a radiation exposure associated with CT, and every study has an ethical consideration to be put if you're exposing donors to this kind of radiation, and it's not at all an optimal modality for a population level screening. You can't put everybody through a CT for the same thing. Also, the confounding factors of fat in the liver on CT are hepatocyte iron deposition, copper and Wilson's disease, or glycogen storage diseases. So all storage diseases are going to mitigate the fat levels in the liver, and so it's not a great modality, which is also a confounding factor in MR, but less so with newer sequences, which I'll show you. So liver attenuation is affected by even CT artifacts, beam hardening artifacts, and also depend on the kilovolts we use, or for vendor specific X-ray filters, which are different from machine to machine. So which came on the block and which is today even the most sensitive and specific method is MRI. So MRI is a great modality. Here is a T1 weighted sequence where all the blood and the spinal fluid is dark. This is just a white blood sequence, but CSF, which is here in the spine, is dark. So this is an in and opposed phase. How do you identify an opposed phase? When you see this dark black outline of the liver. So what happens, just a small word on the physics, chemical shift imaging is a very, very favorite modality and very good sequence which has been used for years. So the in and out, where's a signal drop, that means this is fat. So anything that's dropping or becoming darker on MR, on a T1 weighted sequence, on an unopposed is fat. So what happens? Usually fat and water, they spin together, the protons. At 180 degrees of the sequence when this is applied, there is a natural spin-off. So the water and fat are at natural diagonals or 180 of each other, which is why when you take this sequence on an opposed ways, a water minus fat picture or a dark picture is obtained. And then a water plus fat picture, which is a water in phase, which is here. So just a little bit of physics there. So we use a Dixon formula. There is mathematics to this, very simple. You use the liver in phase value and use the liver out phase value. Use a spleen in phase value and a spleen out phase value on both sequences. There is a formula here that's x and y. X minus y divided by 2x into 100 gives you the percentage of liver fat. Seems a little tedious, but it's not so tedious if you compare it to the MR spectroscopy, which is still one of the best and gold standards of fat estimation in the liver. Why are we not using it? Because it's very tedious, it has a complex acquisition, and it has a limited resolution. So what you do here is basically take a voxel. A voxel is this little red box. We use the voxel to area particularly one spot in the liver. So if your liver has fatty infiltration, it is geographical, it is not uniformly distributed, this one voxel is not going to help you decipher the area of fat. So you have different frequency shifts. So there are different peaks which the protons of fat and water will give. Subtraction of this peak will give you the area under these peaks and how much is the fat within this particular voxel only. It is not representative of the entire liver. There are multi-voxel techniques, which means you can have a larger voxel which has multiple boxes in it and you take a larger area. Nevertheless, you cannot take the entire liver in one go and it is a more complex procedure. But this is definitely one of the best modalities and has been proven over time to have the most sensitive and specific estimation of fat. So if I ask you a question, which is the best modality to use fat, to quantify fat, it would be spectroscopy. Very good. So MR proton density fat fraction, a big favorite of everyone, can be calculated either through spectroscopy, which I just showed you, which is subtraction of the two peaks. It is very well correlated with histology-based steatosis and has emerged as a leading non-invasive modality today for the reasons why. Because it's very easy to do. It's just a 20-second breath hold. It's a single breath hold sequence. So a person holds the breath for 20 seconds. The liver is one single ROI. So you saw those small ROIs being put on the liver. Instead of that, we take an entire large ROI of the entire liver as a map. It's available from all scanners across the board with all manufacturers. So full liver fat map in a single breath hold. It's highly robust and accurate as a marker of steatosis and very good histological correlation. So when do we say actually that the liver is fat? How much can imaging pick up? What is the marker? What is the baseline where you say that, okay, this much % fat and above is going to be picked up by imaging? You tell me, pediatrics. Guess it doesn't matter. Very good. So 5%. So if you have liver fat more than 5%, that is the only thing that is quantifiable and is marked as fatty liver. So the severity of steatosis with MR-PDFF has been graded as 1, 2, and 3, more than 6.4, more than 17, and more than 22. So these are the three brackets which we are grading as 1, 2, and 3 steatosis. So this is the map. These are all literature images since we are not doing this. So steatosis grade 0, 1, 2, and 3, very well matched. This is a wonderful study in radiographics of 2023. And here you can map with the percentage marker of the same. So let's come back to the original topic that we had today. What is fat being quantified on with ultrasound and what are the different styles of doing it? So a grayscale ultrasound examination, a patient comes to us. So we have these 4 grades which are completely subjective. I see it as X, another person sees it as Y, another sees it as Z. So following ultrasound features, the increased echogenicity of liver, altered renal contrast with liver, and deep attenuation in blood vessels, which I'll just show you. So this is a fatty liver, right? We all agree on this. Why? Because the kidney is darker than the liver. But why should we always use the spleen with it? Why should we have a look at the spleen? Because what happens when the patient has CKD? Right? So when the patient has CKD, the renal echogenicity is not going to be the same. It will be raised. Or the patient has acute kidney injury for that matter. So a lot of your patients have acute kidney injury, right? A lot of ALF patients have acute kidney injury or CLD patients have a kidney injury. So kidney is not the best marker for our subset of patients and otherwise must always have a look at the spleen. So you have a 3 organ relativity. So in comparison to both, the liver ecotexture is raised. Now let's come to how it's qualitative and only subjective, and there's only modest accuracy. So this is mild steatosis for me because I can see all the vessels nicely. Which vessel would we need to compare it with? Should we use the hepatic veins or the portal vein? What is the standard? Anyone? Portal vein. It's the portal vein, yeah? So we use the portal vein. So the walls of the portal vein should be seen nicely. This is the spleen, just for comparison, and that's the liver raised in the kidney. Now in this liver, it seems more bright than the last one, so it is moderate, and this is severe steatosis because we can't see the borders of the diaphragm. We can't actually even see the posterior outline of the liver, and this is much, much brighter than the kidney. So, but this is all very subjective because I may feel this is moderate or somebody else may feel this is severe. So there is, here are the vessel walls, not seen nicely at all. The diaphragm is not outlined well. All when we are seeing vessels is only when we put Doppler in them. So we're not really seeing them as dark vessels on a normal B mode ultrasound. So if you need to ask whether there is exactly how much fat or there is patient with a lower grade of fat and you want to be sure, it's not me, it's Archana's department that's going to give you the gold standard, because biopsy still is and remains the reference standard for both fibrosis and steatosis, and all the other modalities are nothing but just close to estimating whatever we can. And of course, there is a limitation of in terms of variability even with pathology. So even a pathologist 1 to 2 may have differences in their opinion, and we usually underestimate the prevalence of hepatic fat to less than 20% fat till we see it on ultrasound. So which means if you're seeing fat on ultrasound, the patient already has about 20% of fat when they come for a routine ultrasound technique. So like I asked our PhD student here, what are the techniques we use in our institute? Most importantly, we are using controlled attenuation parameter, which is CAP. I'm going to ask you the full form at the end of the talk, so please memorize it. You see this every day on your FibroScan equipment. What happens here with the normal CAP, you see a smaller sample volume. There's no dynamic grayscale to it, and it's a single vendor proprietary technique on the transient elastography machine that we have. It measures the total attenuation of sound. This is definitely more accessible than an MR spectroscopy or a CT. And now what we're going to talk about is what is an improvement on this technique, which is a 2D attenuation imaging. I'm going to come to that slowly. Simultaneous acquisition of grayscale with attenuation parameter of what you get on a FibroScan. Actually, if you combine the two, it's called attenuation imaging on ultrasound. This has definitely got a larger sample volume because you can see the entire liver. So a little bit of how we get this attenuation imaging, how do we get the quantify it? So basically, when you put ultrasound signals through any tissue, there is loss of that energy that you're putting. So a wave goes in, that wave is losing its energy as it passes through the tissue. So based on the tissue property, you get the ultrasound frequency resonated back to you, right? Like a simple cave and an echo back from the cave. So when the tissue is attenuated, it increases with hepatic fatty infiltration. So attenuation of this beam, which means destruction of this beam increases as the fat increases in the tissue. So it's opposite to what you get in a FibroScan. You send an elastography, you send a shear wave in, the harder the tissue, the better is the echo back. So sound travels better in solid, right? So the more solid the tissue, better is the echo back. So you get it is corresponding to the hardness of the tissue. But in fat, it's the opposite. It's softer, and hence the attenuation of the beam increases. So you'll get a lesser value coming back. So this is what they have shown, that the receiving center frequency to the transmit center frequency along the depth will change and it will reduce. So this is a FibroScan machine that you normally use. Okay, what is the unit we use for CAP? Anyone? Let me move to the next slide. What is the unit we use for a CAP? This you see here every day. What is the unit? Hepatology. Or kaun hai? Who else is there? Now answer me, Kavita. What is the unit? It's a sound. So decibel the sound. It's a sound wave. So decibel per meter is the unit of CAP. You have to know this. You cannot not know this in your exam. Okay, so decibel per meter is a unit for your normal CAP values that you're getting along with fibro. What do you measure the FibroScan in? What unit? Excellent. So you know kilopascal. So this is decibel per meter. So what happens in the TE machine? You use that same probe. You use the same probe or you use different probes for CAP? Very relevant question. You use the same probe or a different probe? Same how many? Hands up. Same probe? You're not going to get, yeah, same probe, absolutely correct. You use the same probe, and the same probe gives you values for cap and elastography both. Please visit that room once in a while. So you have 3 sizes of probes. There's a small, medium and an XL probe. Here normally we're not using the XL for the spleen, but we should. And small for children, medium is what we normally use, and XL for a thickened abdominal wall. And the skin to liver capsule distance, this is very important. Usually in a very obese patient, the values you're not getting are not reliable. And the same thing happens with ultrasound. So decibel per meter is the value of the cap that you're getting. This is a fibroscan, and these are the various values you're getting. I'm not going to get into that. So what are the pros and cons of cap that you're doing here? Cap is outperformed by MRI PDFF by its sensitivity and specificity, no doubt about it. But the plus is it's a point of care technique. It's the first thing that you can do when a patient walks into your OPD. Better validated and MAFLed using the XL probe. So when you have a patient whom you know is suspected for that, must use a bigger or an XL probe. There is no yet defined cutoff, and there is a lot of interference by vessels, tumors, ascites, and all these factors, and I'll show you how. And the influence of the BMI as well needs evaluation. Patients who are diabetic, who have metabolic disease, the values that you get on cap are not the defined values for those patients. So that is a big lacuna for cap. This needs comparison with an ultrasound, and there is an overlap in grading as well as the confounding factors of hepatitis and fibrosis affect cap values. So the quality criteria for cap is not defined, although it has been shown to have good performances in advanced fibrosis. So wherever a patient has advanced fibrosis and fat is occurring with it, there you may still rely on it, but anything beyond or less than that, it is not a very reliable indicator. It is of course a very good indicator in children because the abdominal wall is small and you don't have that level of fibrosis so soon. So what is a cutoff for cap which says that there is definite steatosis? It's 249 decibels per meter. I was going to ask you that, but I'll spare you. So center frequency is the one that is affected. So healthy liver, fatty liver, I'm not going to go down into the physics. Only 2 things you need to know. Whenever you send an ultrasound wave into the body, there are only 2 factors that affect the attenuation of the ultrasound. So the ultrasound wave gets attenuated, which means it's destroyed as it enters the tissue. Only 2 things. One is the media through which it travels, which means if there is ascites or if there is fat, it's going to get changed. And if they're both together, it will be attenuated more. And the frequency at which the ultrasound is transmitted. Now, when you use an ultrasound machine, the frequency that you're using is already prefixed, right? You're using a prefix frequency. So the only thing that affects the attenuation is the media. So if you fix the transmitting frequency, the attenuation only depends on the medium, and that is how the machine is now, it's wired, and using the help of AI, it has calculated, adjusted echo intensity, and it estimates the attenuation coefficient or the destruction of sound waves with the help of very good mechanics. These are 3 major mechanisms of attenuation. How it gets attenuated: you lose the energy into heat, you lose the energy into come back, and they lose energy into various directions when you approach it. So how do we do a scan? Exactly like you do a fibroscan when you do a cap. So what do you do when you do an ATI? So the right lobe of the liver is used. You use an intercostal approach always. At least 10 consecutive measurements have to be taken. The probe has to be at least 2 centimeters. Let me show you So this is what you do when you're doing an attenuation imaging on ultrasound. This is the step above the cap, which is what we're talking about today. You can see the entire picture of ultrasound. You use the probe in such a way that it is intercostal. The measurement has to be between 3 to 9 centimeters from the skin to the distance of where you're mapping it. So any depth below 9 centimeters is not going to give you the accurate values. These are the advised parameters, and the box is applied here. If you see that there are areas which are cut off from the box, which is nothing but an AI algorithm being used along with this, it automatically cuts out the vessels within this sampling box. So that is the beauty of this. It cuts out the vessels from the sampling box. This is an attenuation color map, and this is how you measure it. It has to be at least 4 centimeters. Patient should be fasting for at least 4, not 6. And then a megahertz probe, just like we do for an abdomen ultrasound. Supine and intercostal planes both should be used. How do you know if your values are correct? So do you look at this R2 star values. So what is the unit for this measurement, which is attenuation imaging? You add a megahertz to it. So decibel per centimeter per megahertz. And this is how ultrasound attenuation parameter is being measured. Now look at this liver, you have a sampling box here. You have to avoid the larger vessels, and the smaller ones, the sampling box takes care of itself. Areas of reverberation, for example, the diaphragm, you have to keep it away from that. So it's pretty much like elastography with a 3 into 3 centimeter or 4 into 4 as per the vendor specifications. Set the sampling box and it gives you values. So these are different livers and different values are being obtained here. So when do we know that our values are, they're valid, or what we are doing is correct? We have to look at this R2 star value. So this R square value, if it is less than 0.8, this is poor. It has to be at least 0.8, and if it is excellent only, then it will be above 0.9. So this is the only parameter to use and see if you're getting your acquisitions. If this is more than 0.8, only then you're good to go. What is the technical success? If you get out of 10 values, if at least 6 and more are valid acquisitions, that acquisition is called a valid acquisition, and you get your scores, and you can easily measure the steatosis. So there are 2 papers only which I'm going to mention. There are not many studies, but there have been few studies in the last 5 to 6 years, mostly from the Southeast Asian countries and Japan, which is where this equipment was manufactured. Most importantly, Canon came up with this technology the first, and they have a patent on that. So this ASLD group came up with this paper in 2023 where they're using steatosis index and 2D attenuation imaging, and they've used a meta-analysis with external validation. So these are the correlation with MR-PDFF and histology, and it's correlating well with that, but it is not correlating with liver stiffness measurements. So fibrosis is definitely a confounding factor here. What did the study tell us? That there is a significant correlation with MR-PDFF values and histologically valued steatosis. There was a good intra-observer variation, good agreement, and S2 and S3 population. So the only issue with this modality, like any other modality, is the fact that when you have to talk about moderate and severe, the differentiation between moderate and severe is not as good as what it would differentiate between an S0 and an S1 or an S1 and an S2. S2, S3 distinction is still a bit of a gray zone, but nevertheless, to rule out S3, it is a great modality, and in comparison with the MR. This is a group from Korea, from the SNUH hospital. This is a great group. They do a lot of good work on imaging in liver, and they have looked at steatosis in comparison with MR-PDFF, which we know is a reference standard, and they found very good correlation with it. They had a p-value of rho of 0.66, and PDF thresholds all were matched. So what is the future? Now, this is what we have today. 2D attenuation imaging is what we have today. And now what are they looking at? So now we are coming up with something in the future we have to look forward to. Ultrasound-derived fat fractions. So this is the key game changer in the next coming years, where you get an ultrasound-derived fat fraction just like MRI PDFF. You don't need to put the patient through an MR. It's a great non-linear regression of attenuation coefficient. They use a backscatter, which means when you send the waves out, there is a backscatter as well, which hampers the attenuation value. So putting all that together, there is a multi-voxel that is applied in the liver on ultrasound, and you get good values in percentages where it shows a linear relationship with PDFF. So slowly and surely you will be replacing MR-PDFF with the ultrasound-derived fat fractions. So that's all we have to learn from this new technique. So what are the take-home messages? Fat decline is a marker of treatment and histological downstaging. It's very important for us to look at it in the mast cell group. The advantages are that ATI includes the ultrasound. You can see what you're doing. It is a more objective criteria, definitely more than anything else we're using right now. And it can be used for standardization, whereas AI algorithms can be added on this to actually predict scores and various different etiologies and not just identify fat. So that's it.